But what about better treatments for COVID-19 patients? I said earlier we made a lot of progress in learning how to manage and treat the disease over the past months, but I think has been a lot less than it should have been. Strikingly, the most useful advance in treatment involves the repurposing of a drug that is already in widespread use entirely off patent, the steroid dexamethasone, which is effective in helping severely ill COVID patients avoid a deadly and detrimental immune response. As a professor of medicine, my inbox is filled with scientists and physicians who have ideas for similarly repurposing existing drugs, vitamins, minerals, and other therapies for early treatment of COVID-19 infection. For many of these ideas, there are good pathophysiological reasons and observational evidence to believe they might work. However, there's no randomized trials to evaluate whether they work. Doctors are free to use them off-label, that is, the FDA approved them for use for some past other indication, but they lack a gold standard evaluation of the efficacy of outpatient management, so most doctors will not use them. So to me, the question is, before dismissing these treatments as effective because of lack of randomized evidence, I think the question we need to answer is, why have there been so few randomized evaluations, especially large-scale ones, of these therapies? And for that answer, I'm going to put on my economist hat. For drugs and therapies on patent, a patent holder has a strong interest in running randomized evaluations, navigating the drug through the FDA's approval process. By contrast, for drugs and therapies with no patent holder, no one has much interest in funding expensive randomized trials or working assiduously to move the FDA regulatory process for rapid approval or even slow approval. The bottleneck then is not the FDA. It's the lack of a residual claimant for these drugs and treatment. Investigators working at academic medical centers may have a reputational interest in evaluating these drugs, and as we've seen, frontline doctors have an incentive to find good treatments for their patients, but they must find funds from somewhere for them, and pharmaceutical companies typically have no interest in it. In principle, the NIH exists to solve this market failure. It could and should use its resources to help fund randomized evaluations of these drugs for off-label purposes. And it has funded some important drug evaluation work, such as a study to determine the right dosage and metabolism of drugs prescribed for children with COVID-19. It's also funded some trials for drugs that for hospitalized patients. For the most part, though, they funded trials for on-patent drugs. The NIH has made comparatively little effort to catalyze randomized evaluations of off-patent drugs for COVID-19 therapeutics. By contrast, the NIH has devoted considerable resources to aid the COVID-19 vaccine randomized trial studies. Even the highest profile randomized evaluation of dexamethasone was not funded by the NIH. The NIH's relative lack of interest in the rapid randomized evaluation of non-patented drug represents a government failure that has likely led to worse COVID-19 outcomes than we would have had otherwise. Thank you for the opportunity to testify.